morning. My name is Joe Lombardi, and the Chief of Vascular Surgery at Cooper University Hospital. And today I have with me Frank Arco, who is also Chief of Vascular Surgery and Endovascular Surgery at Sanger Heart and Vascular Institute at Atrium Health. We're going to talk a little bit about Shockwave and calcified vessels today. So Frank, thanks for coming with us today.
Thanks for having me.
These discussions are always fun because these challenges in vascular surgery sometimes have been perpetual, and namely calcium in arteries. So how has that influenced or been a problem in your practice in terms of calcified vessels and access?
It's interesting. I've always thought that calcium was the nemesis of open endovascular surgery. It's difficult to manage. It's difficult to manage from an endovascular solution to remove it. It's difficult when you do open surgery, not to remove it, but to actually get some proximal and distal control when that calcium sort of extends proximally and distally to even where the occlusive lesions are. So I think that we're getting new technologies coming around. I think IVL is technology that has really been a game changer for some of these procedures that we'll show you a little bit later. But I think it's been a real advantage to the patients in sort of improving their recovery and improving the results, improving stent vessel apposition. It doesn't work all the time, but I think that it's certainly a solution that helps the majority of the time.
Thanks for the thoughts. I believe you have a case for us to look over here. So,
I do. I think this is sort of my typical cases that we tend to get in the Carolinas. We get a lot of calcium. I'm not exactly sure what they eat. I know they smoke a lot, or they used to. But this is a 78-year-old woman. Actually, what her biggest issue is, she's got an abdominal aortic aneurysm as well. It's not a huge aneurysm. It's about 4.8 centimeters in size. It was referred to me because the aneurysm has been increasing in size. I think it grew greater than 5 millimeters over the last 6 months. She was referred to me because the referring physician thought it was going to be very difficult to access. And then you can sort of take a look at this axis, both on these are sort of some representative film just due to time. But you can see both the common as well as the external iliacs on the right and the left side. And you can also see that very, very small distal aorta. Then you look at the intraoperative arteriogram prior to intervention, you can sort of see this almost like coral reefing in the common iliac. These vessels were not very large. They're probably measuring right around 7-8 millimeters in the commons. The externals are right about 6. But with the calcium, the luminal size is actually much smaller. I thought this was going to be a very difficult case. The other thing that worried me a lot about this case, and you can make an argument for doing this, was the distal aorta was quite small, and whether or not I was going to be able to fit both of those lumens within that. You could easily make the argument, and I wouldn't give anyone any issue if they just did AUI with a fem-fem. That's really sort of not my favorite procedure. I don't really like extra anatomical bypasses. I think they serve a purpose, and this might have been a case, but this one actually worked well. I was really going to use the L6s, the M5 Plus as well in the external. Becomes a costly procedure because you can typically maybe get by with one balloon. And then just use it through all the iliacs, but it really needed 2 different sizes, so it becomes expensive. But if you can limit this and sort of keep this to an overnight and sort of avoid conduits and things like that, I think you sort of make up with that in the future. So here we've gained access. One of the nice things about the L6 is it's not on an 014 wire, it's actually on an 018, so it gives you a little bit more support. Here I've got in the iliacs with the 9, sort of utilizing 150 pulses. I did up to about 2 atmospheres, so I didn't really go up to the 4 atmospheres, and then also did that on the contralateral side. Again, here utilizing one balloon, so 150 pulses on one side, 150 on the other. You could use kissing balloons in this fashion, but I knew I was going to need to use the M5 Plus for the external iliac, so trying to limit that a little bit. And then here we are into the external iliacs. I sort of went gentle on these. I get a little bit concerned in a woman with going after bilateral external iliacs simultaneously because of the potential risk for rupture. Again, I did these with relatively low pressures. I did use 2 balloons on here just for the sake of time, and I had limited to the 1 balloon up at the top. So This is actually what you sort of see post-IVL treatment. So this is without anything else. There's no stents within the common iliacs. Clearly, I'm going to stent the common iliacs because I have to fix the aneurysm. And I probably need to stent those externals. But the one on the right actually looks pretty good. But you get a little bit of dissection over there on that left side. So I'm gonna treat those. And again, these were very, very small. You can just see how small that is down by the common femoral. I did bilateral cut downs on these. I did not do these percutaneously, and I did have to do a little bit of endarterectomy on the right side post procedure. So I used Endurant graft for this. I sort of extended it all the way up to the iliacs. There's a little bit of a type 4 there. Was able to bring the stent grafts all the way down to those common iliacs. With that pre-dilatation with the IVL, you can really see I've got very nice stent to vessel wall apposition. You don't really see that infolding of that self-expanding stent with the calcium. And I think that was advantageous for this post-procedure as well as pre-deployment because I was able to get it up without really doing a conduit. This was not easy to get up. Even though it's up, I still sort of had to give a fair amount of push up. With the cut down, what I will do with the 20 French, actually this was 18 French delivery system, I will oftentimes just go underneath that inguinal ligament with my finger and sort of use it as support as I'm pushing up over the 035 wire. You can also use sort of some external pressure for that, but with the cut downs, I do that. So nice result here. And she actually did quite well. I was in the hospital overnight, was actually discharged. I think she was discharged not the first post-operative day, the second post-operative day, mainly because she lived for about 2.5 hours away, and I like to keep them just an extra day or so.
Yeah, in my practice, we see a lot of these cases, and this thing is, this technology has really been a game changer for us in terms of how we tackle it. The use of extra anatomic bypass, as you mentioned earlier, not a big fan either. I really don't like putting prosthetic in the groin when I can avoid it. But this has really changed my algorithm altogether. That was a great case. I appreciate it. You bringing it to us.
Would you have done anything differently in that case?
No, I think that's the algorithm I would have chosen. I don't know if I would have been as successful as you.
Well, probably.
But
I suspect.
Yeah, but you mentioned it earlier as well that even though you'll pave a nice, you'll have a nice angiogram after you're done, delivery can still be an issue with these shelves of plaque that limit your ability to get those sheaths up. So the finger technique, I kind of like that. Yeah. Well, Frank, thanks again for giving us your perspective on this new technology. We appreciate your thoughts.
My pleasure.
And also thanks to the audience for viewing, and have a nice day.